Hello, and welcome to the next session in our prenatal education series. My name is Kim Fernandez, and if you haven't seen me before, if you haven't watched any of our other sessions, I'll give you a brief introduction of myself. I am a certified labor doula, a certified childbirth educator, and a postpartum doula here at the Toronto Doula Group. I've been working with families in the birthing world since 2006, and I also have 3 children of my own. They are now young adults, and I couldn't be prouder of them. All right, so this session is what happens to baby in the first 24 hours. So let's get into this. I want to make it clear, though, that in these sessions, of any of the sessions that you watch with the Toronto Doula Group, that this is not medical advice. We are really here to lay out your options for you, and then you get to decide what might be the best option for you and your family. It's going to be important for you to make sure that you are asking your care provider questions, those benefits, risks, and alternatives, and that you're using that information and making the best decision for you and your family. If you have any questions about what you see in this session or any of our other sessions, please feel free to email us at support@torontodoulagroup.com. In this session, we are going to learn about the various procedures that baby will come across while you are in hospital throughout the 24-hour stay that you are there for vaginal birth. And we'll also talk about which of those might be optional and which are necessary. We'll also discuss how these procedures are done and when in the flow of the 24 hours that they are done. And we're going to talk about this on the basis of a vaginal birth, our baby. And even though we are talking about this on the basis of a vaginal birth, this will all happen with a cesarean birth as well. So whatever happens, if you do end up having a cesarean birth, all of this stuff will still be the same. So what happens when baby comes out? They're going to come out and they're going to go on your chest, however long that cord is, and they're going to be rubbed and invigorated with a receiving blanket. And we do that to get baby to cry. We don't smack babies anymore to get them to cry because, well, that's super mean. So what we do now is, in an effort to dry them off and keep them warm and get them to cry, they're going to be rubbed vigorously with a receiving blanket. And at the same time, they're going to have their first test. And that test is a visual test. So baby doesn't have to leave your chest or your belly in order to have this test. It's called the APGAR, and it's all done visually. It's done at 1 minute and 5 minutes post-birth. And they say that APGAR stands for Activity, Pulse, Grimace, Appearance, and Respiration. In reality, stands for the doctor who created it, Dr. Roberta APGAR. And basically what it is how is baby doing now that they are earthside? Are they breathing? Are they pinking up? Are they crying? Do they have muscle tone? What's happening with them? So there's 5 sections that are marked 2 points each, and nobody gets 10. So 10 would be full marks. 9 is usually the highest that you'll get. And the reason for that is because the 1 point that is usually missed is color. When babies come out, they actually look fairly gray until they really start breathing on their own and oxygenating their own blood. So if at 1 minute things aren't great, and that would be anything under 7, usually by 5 minutes it's fine. If by 5 minutes it's still not great, what they will ask to do is the care provider will, or the nurse will ask to bring baby over to the warmer, and they will listen to baby's lungs, do some suctioning, things like that, invigorate baby a little bit more, get them to cry a little bit more. And then there's another APGAR visual test that's done at 10 minutes. Now, the one at 10 minutes is usually not necessary because usually by 5 minutes, baby's fine and they can stay right where they are. But if they do get taken over, it's just because the care providers are being a little bit more cautious with baby. Now, you won't hear them tell you, they won't necessarily tell you what your score is. You can certainly ask, and it will certainly be on the paperwork that you are given when baby leaves the hospital, when baby is discharged. But even if your baby gets 10 and 10 or 9 and 9, it doesn't mean that they're going to Harvard. Basically, all it means is now that they are Earthside, they're fine to stay right where they are and everything is good. The next thing that happens with baby, all in that same sort of time frame, is they will clamp baby's cord. Now, most hospitals in Toronto, which is where I am, most hospitals will do a 1 minute delay automatically of the cord clamping. And the reason why we do this, or that they do this, is because the blood that's in that cord is not cord blood and it's not your blood, it's actually baby's blood. And if we delay that clamping, the amount of blood that's in there will travel back to baby after they are born. The placenta will pump it back into baby. And we know, studies have shown us, that babies that have their cord delayed in clamping are less likely to suffer from anemia and have higher iron stores. And that's not just for the initial newborn period. A longitudinal study has shown us that actually happens even upwards of 18 months after the birth. So if you are not cord blood banking, then doing a delay of 1 to 2 minutes is perfectly fine. The hospital may automatically do one of 1 minute, but you can certainly ask for it to be longer. A British study showed us that as little as 90 seconds was enough to get about 80% of that blood back to baby. If you want to have a little more information on delayed cord clamping, there's a YouTube video by a woman named Penny Simkin. Her last name is spelled Simkin. And she talks about sort of the benefits of delayed clamping. And she also talks about how much blood we're actually talking about. And for a baby this tiny, it's actually as much as a 500 milliliter bottle of water, which is a lot of blood for a baby to not have back. So if you are cord blood banking, however, there are some companies that will suggest that you can do a delay and a clamping and a banking. However, that's not entirely true. We don't know how much is going to be in that cord. So most care providers will clamp right away because you do need to have a certain sample size in order to store it. So because of that, and because we can't predict how much is going to be in that cord, they will clamp right away. So if you are going to do or if you're on the fence about whether to do the banking or do a delay, I suggest you look at that Penny Simkin video, but I also suggest that you look at your own medical history and what they can do with the banked blood. If there's overlap between what they can do with it and your medical history, then it may be a insurance policy that you could potentially use. If there's no overlap, if your medical history doesn't have anything in it that they would actually be able to treat, then it may be an insurance policy that you never use. So you want to look at all sides of the coin and assess what might be best for you and your family. Okay. All right. Next on the list, and we're going to put these two up together, the eye ointment and the vitamin K. The eye ointment currently an erythromycin clear gel that is put into babies' eyes or put onto their eyes to basically protect them from any sexually transmitted infections that you may have. So even though you've been tested at the beginning of your pregnancy for a sexually transmitted infection, every baby gets this. Though there has been some, not delay, but there has been sort of a push to have this eliminated. And many hospitals in Toronto now are not necessarily offering the eye ointment. So the eye ointment basically is a public health checkbox that was done since the end of World War I. It was when the soldiers came home from Europe. There was a large sort of flood of babies being born to women being infected with chlamydia and gonorrhea, and babies were coming in contact with it and having eye issues as a result. So it became a bit of a public health crisis. And at that point, then all babies were given, at the time it was silver nitrite. All babies were given silver nitrite to protect their eyes from the chlamydia and gonorrhea. So nowadays it is erythromycin, and the Canadian Pediatric Society came out a couple of years ago and indicated that it isn't a necessary procedure anymore unless the birthing parent falls into a high-risk category. And that high-risk category would be homelessness, a sex worker, multiple partners, or a previous sexually transmitted infection. So if you fall into any of those categories, then the eye ointment is probably a good option to have. What we've done in the past when everybody was getting it, whether they were in a high risk category or not, is we were asking for a delay. And what that delay did was is it allowed for bonding visually between baby and the birthing parent. Well, babies can't see when they come out. Oh, yes, they can. They can't see very far, but they can see. And the distance they can see is from here to here, which is all nature needs them to see. And that's so that they can bond with the birthing parent. So the eye ointment nowadays likely won't be offered. However, if it is, you can certainly ask for a delay if you know there are no sexually transmitted infections. The other thing that happens is at the same time is there's usually a shot of vitamin K, and we used to delay this for an hour as well. Now, the vitamin K is a checkbox, but it's also a necessary one. We as a species are a bit deficient actually in vitamin K, and the birthing parent doesn't usually have enough to give baby until they can start producing it on their own. And vitamin K is used for blood clotting. And because we don't know if baby's going to need any unforeseen medical procedures where they will need to clot their own blood, we give baby a small amount until they can start producing it on their own, which is done in their gut and their fat stores. So it is, as I say, a checkbox, but it is a necessary one. And it's usually an intramuscular shot in baby's thigh. However, if baby is skin to skin with you or on the breast when the shot is given, they often don't feel it because when they are in that position of being skin to skin or feeding, they usually have a much higher pain tolerance and they might not actually even notice it. So a good option too, when you're going to be doing any vaccinations, is to have baby either skin to skin or at the breast when those needles happen, as I say, because they likely won't notice that it's happened. And most hospitals will do that now anyways. All right. There will also be a blood test. So the blood test that's done is a heel prick, and it is just a small amount of blood actually from the heel, and it can test so many things. So it will test a laundry list of metabolic diseases that might require baby to eat differently. And it will also type baby's blood and test baby's bilirubin levels. Now, that test is the jaundice test. So the jaundice test is to determine whether baby has high bilirubin levels and may need to be treated. So most babies actually will test on the higher side of bilirubin, and it's usually not an issue. What that is right now, baby's internal organs are not dealing with any of baby's waste products. All your internal organs are dealing with baby's waste products. When baby is born, it's like their system comes online. And unfortunately, though, their liver is just a little bit immature to deal with the byproduct of those dead red blood cells, which is the bilirubin, because that's where it's filtered. It's a little bit immature to deal with the amount of it, so it kind of gets backed up. And it builds up in baby's system and it gets close to the surface of the skin, and it's what gives baby that yellowy color. Now, nature has seen that this is an issue for us humans, and it has given us the fix. So the fix is the colostrum. So the first milk that you have, which is very thick, yellow, and very sticky, and it actually acts like a laxative, and it pushes all of this junk out of baby's system. And it comes out in the form of that black, sticky, nasty poop that you're all so excited to get to. So when the poop begins to change color to a more lighter green to eventually a bright mustard yellow with Dijon seeds, then we know jaundice isn't an issue anymore. So getting baby on the breast quite frequently, if you're choosing to breastfeed, quite frequently in the first 24 hours is going to be helpful to push all that stuff out of baby's system. If you're choosing not to breastfeed, then feeding baby again, frequently throughout the stay in the hospital is going to be helpful again to sort of push all this stuff out of baby's system. If, however, it doesn't leave baby's system fast enough or they're concerned about the level, then baby will likely have to stay and they will be admitted to the special care nursery or the NICU, and they will be put into an incubator with just some funky sunglasses and a diaper, and they will be in the incubator under blue lights because they know that the blue spectrum of lights will burn off the orange pigment, which is close to the surface of the skin, faster than any other color. So, and baby will be tested repeatedly until their levels are at a point where the hospital staff are comfortable for them to go home. Again, it will still be, even if baby is admitted to the neonatal unit for jaundice treatment, it will still be necessary for baby to feed frequently. And getting that colostrum in them will be helpful to speed up the process. All right. When you get home, actually, before I move on, when you get home, you will have to take baby to their care provider, either a family doctor or a pediatrician, within a couple of days of leaving the hospital. And in that time, they will also be looking at baby's color and output and all of that stuff to make sure that jaundice isn't still an issue or isn't going to be an issue at some point. And finally, baby will have a hearing test. So basically what will happen is a nurse will come in, she will put some sensors into baby's ear, and they will make a noise, register the vibration, and dun, 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 your baby can hear. Again, that will be put into paperwork that you will take to baby's care provider within 2 days of leaving the hospital. And those will be well baby care checks that we will, or that they will be monitoring baby from that point on. All right. And that's it. Those are all the tests that we have for babies in Toronto. If you live in another region of Ontario, if you live in another region of Canada, if you live in the United States or elsewhere, there may be further testing or other things that might happen with baby while you are in hospital. So it'll be important to make sure that you scope out what is being done in your region. And again, ask those benefits, risks, and alternative questions of your care provider to make sure that you understand what is happening to your baby. Now, if you enjoyed this session, I'm really happy. And if you would like to learn more about your labor, your birth, your postpartum, we have other sessions available. We have our anatomy and physiology one, which is free, and maybe you've already taken that. We have medical interventions, medical pain management, non-medical pain management, so comfort measures to use before either getting an epidural or getting to the end without one, cesarean birth, feeding your baby, and your postpartum recovery. We hope that you'll consider taking the rest of these sessions. And if you have already taken some, thank you very much. Again, if you have any questions at all about this session or anything else that you've heard, please don't hesitate to email us at support@torontodoulagroup.com. I hope you have a great day, and thank you for listening.